History of medicine's fun. This is easily my favorite one though, because there's nothing that kind of showcases the amazingness and just the pure insanity of the development of medical activity than the history of surgery. So, jumping back to some of our earliest stuff, Galen, back in the early Roman era, who was a Greek physician working in the Roman Empire, started actually in the gladiatorial arenas. That's how he got his start. And back when dissection was not allowed, you can imagine having a gladiator arena doctor might be the only person who's getting a good look at internal anatomy with any kind of regularity at that point. So as we discussed before, Galen did a lot of amazing things. He discussed respiration. He talked about how nerves and muscle are linked, and that if you cut a nerve, it's going to kill off the activity of that muscle. He also linked a lot of theories like the pneumatic theory with the humeral theory. And one thing for surgery that he did that really turned out to be a negative is he believed in laudable pus. Now, laudable, it's not a word that we get much use out of anymore, but it means praiseworthy. And the idea here was that if you saw a wound healing and there was pus on it, there was actually pus that was good. You wanted to see that pus. And the problem is, sometimes, as you guys know, you get healing by first intention. Stuff heals nicely and you're good. Well, they thought, because of this laudable pus theory, that you had to see that pus. So they might take a perfectly good wound that was healing and open it back up until it actually got infected. And some pus spread centrally and can kill you off, others not so much. But it basically set up this idea that pus was something that was not just a natural part of the healing process per se, but a necessary part. So he became the physician to the emperor and moved on to more what we think of as intellectual activities. And we've talked about how the ancient Greeks really strongly separated the manual from the intellectual. And sadly, that's going to have a lot of implications for surgery, because when it comes to medicine, you can think of physicians as being the people who do the thinking and surgeons as the people who do the doing. And if you think that is in the past, just envision in your head the ideal ortho bro. Yeah, the smiles on your face tell me you know exactly what I'm talking about. So surgery, again, developed in Greece, moved into Rome, and then after the fall of the Roman Empire, the Islamic caliphates in Baghdad, Damascus, and also in modern-day Spain were practicing a lot of those procedures. And even though dissection or cutting up the body wasn't allowed, they actually got very good at doing external treatments like cautery and looking at how to fix the eye, especially when cataracts would cloud the lens. So there were medical devices that came around as a result of this, although there wasn't a great deal of actual surgery, if you think about surgery as cutting open the body, taking place during the Islamic empires. So al-Zahari did write a book on surgery. He was in Andalus, or the what's now Spain, and described a great deal of the mechanics involved and the tools that would be used, and essentially brought in the idea that instead of always using cautery to fix wounds, you could actually use catgut threads to suture it. Now, sadly, that knowledge got lost for many years, and it reverted back to being that anytime you had to heal up someone's body, you had to use cautery. And if you think about cautery in the medieval era, what's that going to look like? Red hot irons, exactly. So what was going on in Europe during all this time is pretty much what we picked up on before. Physicians were the high status people. They would maybe look at the urine. They might kind of look at some books to figure out what sort of herbal remedies to give to somebody, but they didn't do any of the actual labor of it. They didn't do the actual dispensing. That's what apothecaries were up for. So they were high status, and there's a huge difference between them and the barbers and the surgeons. Now, initially, barbers and surgeons were very closely connected. Barbers technically were the ones who drew the blood, so if a doctor prescribed bloodletting, the barbers did that, gave enemas, pulled teeth, and cut hair. And how do you advertise in a non-literate society, in a place where most of your people are not going to be able to read? If you want to advertise that you can cure wounds, you just take a pole and you wrap a bloody bandage around it, and that's how we got our barber pole. So that's going to be the sign that that was where a barber was working. You could go there to get a wound bandaged, a tooth pulled, things like that. Now, what's really interesting about this is because these people were actually doing work and making observations, they were positioned really well to make some innovations and discover things. The problem was the barbers were largely kind of set up in kind of a hereditary or apprenticeship style. So you were only really going to get as much training as the master in that apprentice relationship was able to provide. And they were largely non-literate. So no matter how good someone's technique might have been at these things, that technique usually died off with them or within a few generations of their apprentices. Monks actually were doing pretty well at developing new surgical things, but the Council of Tours in 1163 actually forbade the monks from doing manual labor like that. So they actually had to stop doing surgery. And since they were basically the only large group of people who were literate, it basically meant that surgery and medicine stayed at that basal level of activity in Europe for a good long time. So the barbers and the surgeons were kind of nebulous. If you go from country to country in the European world, the definition for who was a barber, who was a surgeon, and who was a barber surgeon really varied. And I will own up to it that I cannot even tell you exactly what the distinction is because it varies from place to place. But in 1210, the College of Paris actually separated the barbers from what were called the long-robed surgeons. These surgeons wanted to kind of mimic the physicians. They wore long white robes to kind of show that they were intellectual. They were surgeons who actually did, read their Aristotle, did their thinking about the humoral theory and so forth. In other words, they were taking themselves out of actually doing the real work. So they were trying to become academic surgeons, not in the sense of innovating, but in the sense of not actually having to lay their hands on people. So the surgeons were actually kind of varied from country to country in how they were let out. In England, barbers and surgeons were pretty much separated pretty strictly from about 1540 on. And so some barbers had the blue and white pole, and they pulled teeth, drew blood, cut hair, whereas academic surgeons were the ones who inherited that red and white pole, and they would do things that were a little more involved, like amputations, trying to heal wounds, do the cautery, things of that nature. So it's unfair to say that the Middle Ages were truly a dark age and that nothing happened. I think it slowed down considerably. There was a lot of reliance on authority rather than new discovery, but there were some bright spots in medieval history. And for surgery, one of them was this guy. He was a French surgeon named Guy de Chauliac. He studied medicine at Montpellier and went to Bologna to continue studying, and then became the physician to three of the popes who were in Avignon. If anyone doesn't know, the papacy moved from Rome to France in the Middle Ages for about 80 years, and he was attendant at the Pope in France at that time. And he actually caught the plague but survived and was able to kind of give a good description of how that progressed. The Pope he was working for actually survived it too, because he said, lock yourself up in a room and keep fires burning all the time to kill off the miasma that's probably causing this disease. Well, being locked in the room and separated from everybody else was probably what actually helped him stay safe. But he wrote a lot about surgery and did actually look at ways to make surgery better. He investigated how to do things like cure ulcers, or at least help them heal faster, looking at hernias. Who here, and you guys, even you second years, you haven't had GI and repro anatomy yet. Who knows what an inguinal hernia is? Okay, so inguinal hernias, a lot of times if they're indirect, it's a loop of intestine that pushes out of the abdominal wall and comes to rest in the scrotum in a lot of cases, if it's an indirect inguinal hernia. The standard of care for hernias at the time was castration. Yeah, not only does it not fix the problem, it's going to create a whole lot more problems. So Guy de Chauliac and others actually looked into ways that they could improve this process and look at how it would actually be beneficial to do other things. Now, like anyone else in the Middle Ages, he was very reliant on the authorities that had come before, and he was very familiar with al-Zuhari, Avicenna. In fact, a lot of the Islamic authorities at that time, people in France would get information from Spain because Al-Andalus, Spain, was so close to France. So there's actually a lot of intercourse between them intellectually as well. Now, the next big surgeon is someone who's going to be coming in at the end of the late medieval era, and his name, he's also French, he's Ambroise Paré. Now, real quick, who's seen pictures like this before of like the wound man, things like that? Some, not all? So once again, this is a book that he put forward describing how his method of surgery worked, but this is actually advertising. It's basically showing you on the cover, hey, do you need to treat people who've been cudgeled in the head, shot with an arrow, got a spear to the foot? this book will tell you how to heal and treat people with these afflictions. So it's basically a way of showing what kind of information is going to be on the inside. So in France, we have the long-robed surgeons who are basically at odds with the academic physicians, but also with the lower-class barber surgeons who they see as not being on par with them socially. But these low-class surgeons, as I mentioned, were probably the people who had the most skill developed over the course of their practice. So Ambrose Paré was too poor, didn't have the education to read Latin and go to college, so he became a barber surgeon working in the French army. Now, what's really interesting about him is he really embodied that late medieval, early Renaissance idea of experimentation. He and Vesalius were contemporaries and really kind of had the same attitude of actually trying to prove what they were doing. And in the case of Paré, it was really interesting. It all happened in one fell swoop. He was working with gunshot victims. Firearms had just come into play in the European theaters of war, and at the time, when they had people who'd been shot, they thought that the toxins in the gunpowder were actually more dangerous than the bullet or the projectile that was lodged in them. So what do you do to deactivate those poisons? Well, obviously, you pour boiling oil into the bullet wound. That was the standard of treatment to deal with those shots. So as a well-trained surgeon, he would do that, but one time he ran out of oil, and he was really worried that he was going to be failing his patients and leaving them exposed to these gunpowder toxins. So he whipped up a poultice with, I think, egg whites, some herbs, things like that, and convinced that he'd actually killed this person off due to his negligent care. He was shocked when he discovered the next day that the guy was actually healing way better, surprise, surprise, than the people who had boiling oil poured into their already traumatized bodies. So at that point, he just decided that it was time to experiment, to actually look at how things worked and see if other alternatives would do any better. And he spent his whole career refining surgery and actually trying to get what we would think of now as sort of an evidence base for that. So he wrote about 20 books, and they became surgical mainstays for almost 2 centuries. Now, the other thing that was interesting is he worked with the army, and because he was very effective and he actually cared about the soldiers under his care, he was incredibly popular. And in fact, he, in addition to stopping castrating people for hernia, was actually celebrated by the army. They actually smuggled him into a besieged city and had a parade just carrying him around on their shoulders because they knew there was actually somebody who, A, cared if they lived or died, and B, might actually have the skill to help fix them from their different wounds and so forth. And, oh yeah, so there we go. So the army was so happy they paraded him around. Now, while we're on this topic, it's not a great thing, but it's an inevitable thing that medical advances, particularly in surgery, come along with warfare. Warfare, as we come up with better and more effective ways to kill one another, leads to different and more traumatic types of injury that then have to be dealt with. So having these sorts of escalating arms races cause kind of a refractory escalation in surgical practice as well. So in the 1300s, basically, this was about the first time somebody really attempted to care for people on the battlefield. Prior to that, they were just kind of left there to be either beaten to death by peasants or starve, freeze, whatever's there. So in the 1300s, Paré started working with the soldiers, introduced arterial ligature from his study of the Islamic physicians in Spain, rather than cauterizing everything, worked on battlefield amputations to try to get people out of the area as quick as they could. In the 1770s, Washington, in the Revolutionary Army, introduced smallpox inoculations so that people could actually stay fit long enough to fight and keep going, whereas the British and other mercenaries on the other side were not able to resist the disease as much. 1850s, you may have heard of Florence Nightingale. She was an upper-class British woman who went into nursing, which at the time was a very low-status career, and modernized it by bringing a lot more hygiene and care to soldiers who were fighting in the Crimean War. And during the American Civil War in the 1860s, one thing that actually came about, we always hear about the medical horrors of the Civil War, and this doesn't diminish them at all, but battlefield transport, getting patients off the battlefield and into a theater where they can actually have amputations done, was something that came up during the Civil War. Anesthesia actually did exist in Civil War period, but it was very tough to come by, and we'll talk more about it in just a second. Now, during the Franco-Prussian War, vaccination instead of inoculation with smallpox was used to actually try to keep the soldiers healthy. And in 1914, after World War I, the actual work of taking care of not just people on the battlefield, but veterans with long-term debilitating wounds like facial trauma and prostheses actually became to be something that was very keen. And if anyone finds that interesting, there's a great book that came out last year called The Facemaker about a woman who actually really made it her life's goal to kind of come up with facial prostheses that allowed people to, disguise and get along socially despite very massive disfigurement of their face. In the 1950s and 70s, during Korean and Vietnamese conflict, that brought much more rapid transport with helicopters, things of that nature, neurovascular repair, and eventually understanding that PTSD was another thing that afflicted people long after the battle might itself be over. Iraq and Afghanistan, more recent wars, we've come to understand how compressive forces like explosions can actually cause long-lasting diffuse axonal injury, traumatic brain injury, and things of that nature have become a lot more inevitable, but also something that we're dealing with as a result of those conflicts. So you can see how the type of treatment we get depends a lot on the type of injuries people receive. Now, one constant struggle in war is, well, in anywhere, but especially in war, is hygiene. So, real quick, what is the first American war where our military lost more soldiers in battle than to hygiene or food-related disease or infection? Give me some ideas. Give me a shout out. Civil War. Okay, well, we got Civil War on the map. Korea. Okay. It's the first Gulf War in the 90s. Yeah, no good saying, oh, that was totally my guess. Oh, yeah. Okay. So it's that recently that the infrastructure for hygiene and food safety has been enough that that has ceased to be the major killer of soldiers in warfare. So Paré was very, very well respected, and was the French king eventually forced the academic surgeons to take him in and kind of put aside the Latin test that you would have to take to be kind of considered a high status surgeon. Now, one of my favorite stories ever, though, is in 1559, Henry II was jousting after a long day and received a massive jousting wound to his face. He actually had this jousting lance go through his eye socket and through part of his brain and face, but he survived, at least very temporarily. Now, Ambrose Paré was on hand because this was a wedding celebration. He was one of the royal surgeons, so he was there and started trying to treat him. Now, the physician for the Holy Roman Emperor, Philip II, was Andreas Vesalius. He was the other half of that wedding equation. His daughter was marrying the son of Henry, and so Vesalius and Paré were together in a room, and they actually got decapitated heads of criminals and tried to induce the same injury to those heads to see if there's some way they could treat Henry II and help him survive. Now, in fact, it was a really massive head wound. He survived for a little while, but the infection finally took hold and he died. But they were actually trying to replicate the injury to find a way to treat it. So, in a perfect world, I've learned how to time travel. And I'm one of those people hanging out in the corner right back there, just watching on as these guys actually try to get out and figure out what is going on. Now we're going to shift to England now. And even if you don't know much about history, this is Henry VIII. If you think about famous British kings, this is probably the one you're thinking of. He's the one with all the wives that he, some of whom he had murdered. And essentially, the barbers, the surgeons, the physicians, they were all very separated until they were chartered together by Henry VIII. And the surgeons at this point were given a guarantee that they would have 2 bodies per year to dissect. So the entire surgical kind of schooling in England, in London, had 2 bodies they got to work with per year. Now, Scottish barber surgeons had a separate kind of setup, and they only got 1 body per year. But for whatever reason, they also got the monopoly on whiskey distribution in Edinburgh. Anybody been to Scotland? Yeah, that's a good deal. That is a very good deal. Now, speaking of Scotland, the University of Edinburgh actually became a massive research hub for anatomy teaching and research, and as a result, it became a massive hub for body snatching as well. Now, the Monroe family, I love this, is a family who 3 successive generations held the chair of anatomy at Edinburgh. So for 126 years, you had a grandfather, father, and son in this position. Now, students, the first 2 Monroes were considered to be fantastic. Alexander Monroe the first, Alexander Monroe the second. The third one was considered to be the worst teacher that most people had ever encountered. Charles Darwin actually took classes from him and said he was just horrifically disgusting and foul and used his grandfather's notes without even amending them and so forth. So, but we had these three guys running anatomy in Edinburgh for that period of time. And because we had this hub for anatomical research, body snatching became a really big thing. So these are called mort safes, and people would put them over the recently buried to make sure that they were there for about 2 weeks, at which time the body would 100% be completely unusable for any sort of medical instruction, and then they take the mort safes and give them to somebody else. The problem is, going after bodies in the ground, it's dark, it's dangerous, it's poorly paid. The anatomists themselves were not the ones doing this. They were high status enough they could hire other people to do it. But there's an even easier way. Who's heard of Burke and Hare? Okay, yeah, how did I know it would be you? All right, so Burke and Hare were immigrants in Edinburgh, and they were running a hotel, and one of their patrons died without paying his bill. So they sold him to the anatomists and got what they considered to be a really solid amount of money. Now, waiting around for people to die, that's not very efficient. So when you run a hotel that has, itinerant people coming through, maybe in poor health, you can just start smothering them in their sleep and selling them to the anatomists. And this horrible, horrible story has been turned into a comedy starring Simon Pegg and Andy Serkis. It's hilarious, so check it out if you get a chance. But basically, they would, kill patrons and people around town, sell them to the anatomist in Edinburgh, who was not too particular about looking into the situation. Like, oh, amazing, you guys found another body. What a gift. So he didn't really do much investigation. Eventually, it was brought to light what they were doing because the students in the classes would start to recognize poor people who were like panhandlers on the street. Like, that's Eddie. We're dissecting Eddie. He was just on the street the other day. So it came to light. Hare turned a state's evidence against Burke. Burke was hanged, and in ironic twist of fate, his skeleton now hangs in the College of Surgery in Edinburgh, and his skin was set aside to bind several books, one of which you can see right there. And just because I know you're dying to hear it, the practice of binding books in human skin is called anthrobibliopexy. So remember that one for the Sunday New York Times crossword puzzle. Now, we've got anatomical teaching, despite the very questionable way in which their specimens are arriving, really developing, and a lot more anatomical research is going on, and with that comes efficacy in surgery as we learn more about the vessels, the organs, and so forth. The next two big names in kind of a UK surgery are William and John Hunter. Now, they're Scottish, but they did most of their work in London. Surgery at this time was still considered to be a fairly low-class occupation. Now, it's hard to kind of get a sense of that because now we think of surgeons as being something spectacular. Everybody is okay with surgery, but who here has been an EMT? Okay, EMTs, would you say that despite the fact you're doing your best to keep people alive, you receive the respect and the esteem which you likely deserve? That's a big no. Well, that's what surgery was like. People very much looked askance at surgery. So just imagine in one generation, EMTs going from this unwarranted but kind of suspect class to being like something everyone aspires to. Well, that's what happened with the Hunters. They brought surgery not only more efficacy, they brought it respectability. Oh, and I should mention, dentistry was considered even lower down than surgery at the time. So John Hunter was the younger brother. William, his brother, was a gynecologist, but also taught his own anatomy school. And if you love that, you'll love this. At the time, anatomy teaching at most medical school universities was so poor that rival anatomy schools would open up across the street to actually teach those students, independently. They'd have to pay a separate fee to study anatomy at that school. So think of Burger King versus McDonald's. It might be that kind of thing going on with competition. But William had, started a very prestigious school. He was considered very, kind of well sought after in higher order of society as a gynecologist, and he was running out of time to do his research and his teaching, so he brought his brother John to London to kind of help him out. And pretty soon John not only learned the ropes, but became, an anatomist par excellence. So he was very poor as a student. He just didn't like going to school. He wanted to go out and walk in nature. He really liked to observe things. He didn't like the formality and having to learn Latin to do stuff. So just like Ambrose Paré, when he decided he actually needed medical training to go further, he joined the military. So he worked in the British Army. And when he came back, he was then considered a surgeon, and he was able to go study with some of the big names in London society. Now, you may have heard of some of these guys. If not, no big deal. But Chesterton, who looked at lithotomy, looking at getting bladder stones out. Percival Pott, who was one of the early orthopedists. Hunter trained with them, kind of learned from them, and brought that information, a clinical kind of approach now to his anatomical studies. So John Hunter is my morally ambiguous hero. And when I phrase it that way, because I'm amazed at what the man did in both good and bad ways. So he worked for 19 hours a day sometimes, writing, dissecting. He'd wake up to dissect, he'd write his notes, he'd go visit patients, work in various hospitals, do research. He had house pupils. And basically, his need for bodies turned body snatching into an industry. There was just a constant stream of recently looted from the graveyard bodies coming to his house. But he not only dissected humans, he wanted any interesting animal he could find. So when zoos had their animals die, they shipped them off to Hunter. He would dissect them, describe them, and so forth. And at one point, he went to a sideshow and met up with a guy named Charles Byrne, who was an Irishman who had gigantism. Now, these days, you have options, but in those days, if you're an illiterate, poor Irish person, what do you do if you have a weird physical feature? You show yourself off in a sideshow. So Hunter came, saw this, and he was like, whoa, this guy is amazing. I have to see what's going on. So he basically told Byrne that when you die, I really want to dissect your body. Now, Byrne believed very strongly that the body had to be intact at the time of death to make it to resurrection day. But having gigantism, having a lot of medical problems that were untreatable at the time, he was in very poor health. And he knew that Hunter was coming for his body as soon as he kicked the bucket. So he paid the mortician to make a stone coffin for him, and the stone coffin was to be thrown into the sea. And so after he died, his pallbearers, went, with a cart, took the stone coffin down the countryside, stopped at an inn for some beverages and for the night. Hunter and his friends showed up, stole the body, replaced it with a bunch of rocks, and brought it back to London, got it boiling, and Hunter's museum still has the skeleton of John Byrne to this day. So he was single-minded in trying to get anything he could that got his interest. And as I mentioned, he was very much interested in comparative anatomy too. That is not a museum. That's Hunter's house. He had special built an anatomical museum in his house, and you can see a whale skeleton there. His anatomical description of a whale basically inspired Moby Dick by Herman Melville. Who's read Moby Dick? Okay. Do you remember any of it? Me neither. Yeah. Basically, there's this weird chapter in Moby Dick that just goes into whale anatomy out of nowhere, and basically it's summarizing Hunter's work on whale anatomy. So his country estate was packed full of exotic animals, and he didn't kill them, but after they died, he would then mount the skeletons, inspect the anatomy. Who's heard of Dr. Dolittle? Okay, Dr. Dolittle, the doctor who can talk to animals. The guy who wrote that lived down the street from Hunter, so they think Hunter might even be the inspiration for Dr. Dolittle with his weird assembly of animals on his property. So his comparative anatomical dissections filled this basic house museum that he had. But he was an amazingly brilliant person. He looked at mastodon teeth and figured out that they were different from elephants and that they no longer were around. Extinction was considered to be impossible at the time. So it was thought that no animal could ever go extinct, and he didn't anticipate Darwin completely. He didn't come up with evolution by natural selection, but he got really close 70 years prior to Darwin. But because of the implications of that, that paper was not published during his lifetime. And in fact, the Royal College of Surgeons published it a couple months after Darwin to be like, hey, Hunter figured this out too. We got that. So his career just went all over the place in any kind of different sort of investigation, including auto experimentation. He was doing jumping jacks one night to stay awake and popped his Achilles tendon, and then started tracking the rate of healing as a result. Then he did some dissections on mouse tendons. He decided to figure out one of the pressing medical questions of the time: were chlamydia and syphilis one disease or two separate diseases? And to do this, he found a sailor with syphilis, talked this guy into allowing him to scratch some syphilitic crusts off his penis, and scratch them into his own arm to give himself syphilis and track the course of the disease. He then concluded that chlamydia and syphilis were the same disease because the sailor probably had both and he infected himself with both accidentally. Yeah. He worked with dentists. If you've ever heard of bicuspid, tricuspid, those are the terms that Hunter came up with to bring dentistry into a little more solid academic founding. And he died. He had angina for a long time. He knew that his heart was giving out. He'd have anginal attacks. And he actually died during an argument at a hospital with some of the administrators. And upon feeling his heart seizing up, he ran to a mirror and wrote down as many of his observations on what was happening to him until he kicked the bucket and dropped dead. So that is John Hunter. This is a book about his life. It's fantastic. But as I said, he's my morally ambiguous hero, because you can't defend some of the things he did, but the sheer volume and originality that he had just blows my mind. Now in France, things were a lot different in the sense that surgery got very, very respectable slowly in England. Surgery became respectable all at once in France. And the reason is because of King Louis XIV. Now, just like before, if you don't know your history, but I say famous French king, you're probably thinking of Louis XIV, the Sun King, reigned for almost 80 years. So he was a medical misery. And it's not a surprise. He's multiple times claimed to have bathed twice in his entire life. He smelled so bad that people would like run ahead of him to open windows as he was entering rooms. And because his hygiene was so poor and his diet was so poor, he developed lots of medical problems, one of which was an anal fistula. Now again, you guys haven't had GI, so I'm just going to pretend that it's anatomy class time. What's an anal fistula, you say? Well, it's when the wall of the rectum and anus erodes, forming a separate exit for fecal matter alongside the anus. So it's basically an infected fistula running between those two areas. Very painful, very inflamed. And so he told the court surgeon, you are going to operate on me because I'd rather die than continue living with this thing. And Charles-Francois Felix basically knew he had to figure out a way to do this or he was dead. So he experimented on several peasants with anal fistulas, and some say even some who didn't have them, and they all died. But in the process, apparently he got the procedure far enough along that when the time came and the king had to go under the knife, he actually was able to do a fistula repair and it worked. And he had a horse standing by in case the king died, so he could race away as quickly as possible. But he didn't need to. And in fact, he immediately became a baron, and the king said, surgeons are great. The army has to have them now, and now there are chairs for surgery in every French university all at once. My personal take is, even if you don't know anything about germ theory, what are you going to do with your instruments before you use them to cut the butt of the King of France? You're probably going to wash them. So they were probably a lot more pristine and not bacteria laden, and that's one reason why the king probably actually survived this procedure. So chairs of surgery were endowed, and surgeons became professionals along the way, and they basically stayed that way until the French Revolution came along and the revolutionaries said, okay, there's no more surgeons or physicians, there's just what we're going to call health officers, and they're going to cover both of those aspects. And so that's when that distinction really broke down, and it had nothing to do with the efficacy of those people, just a change in the political climate. Now, surgery has gotten better in the sense that we have an anatomical basis for it. A lot of anatomy research has gone in, but it's still the last resort. People do not go into surgery, even for something relatively minor like a broken finger, especially an open fracture, because it's very likely they're going to die. And even if they don't die, it's going to hurt really, really badly. For surgery in those days, one of the standard things was to have 4 to 8 large gentlemen nearby to hold the patient down because there was no anesthesia. Surgical wings were usually on a separate building far away from the rest of the hospital, so the screams would not be quite so pronounced and audible to the people inside. So people had to be actually restrained in a lot of cases to actually have surgery take place. And what are you going to do if you're a surgeon and your patient is writhing and screaming and jerking around? Are you going to be slow and meticulous, or are you going to be fast? Yeah, you're going to be fast. And that was a good idea at the time. They didn't have the time to be as precise as they'd like to be because they didn't have that luxury. So people had tried to come up with ways to make surgery painless for a long time. Opium and alcohol have been around forever, and they might dull the effect a bit, but it's not going to deaden the pain completely. Ice actually turned out to work fairly well. There was a military surgeon in France who had amputations going on during the French-Russian War and found that the soldiers who'd been stuck on the ice longer before they'd been brought in actually complained less of the pain because of the frostbite and the fact that the cold had pretty much numbed their legs. So he tried to bring ice into operation so that he could actually numb areas before cutting in. Now, that's a good innovation. It's not going to be one that actually is going to work in all cases, but it was something at least. And he also introduced ambulances drawn by horses to get people off the battlefield rather than trying to amputate then and there in the muck and the blood and whatever else happens to be there. So amputations were a major staple of surgical activity, and this is called a falciform knife. So a falciform knife, it's hawk bill shaped like that, and the surgeon would basically clamp the vessel, wrap their arm around the leg or the arm or whatever, and in as short a cut as they could, they'd try to make a big curving incision to go through as much flesh as possible with that big curved knife. So the first barrier to make surgery actually effective that fell was anesthesia, and hooray, it's the first major American innovation. Anybody? Anybody? Yay. So be happy for that. Be unhappy when you hear the rest of the story. So despite being an American innovation, it's a horrible story of greed and envy. And so essentially, back in those days, in the 1800s, people didn't have theaters with any regularity. There was no movies, no TV, no Netflix, anything like that. So people had to find fun in other ways. One thing that people did for fun was they went to laughing gas parties. And that's exactly what it sounds like. People would inhale nitrous oxide, get all giggly, be silly, people would laugh, and they'd all have a grand time. A dentist named Horace Wells went to a laughing gas party, and there's various versions of this story, but pretty commonly what happened is they say he banged his knee really badly on the way back to his seat, but completely overlooked it. Didn't realize he'd hurt his knee until the next day. And being a dentist, he thought, well, if I didn't feel that, maybe I could use this gas to draw teeth. And he started doing it, and it worked pretty well. Being, relatively insightful, he thought, well, maybe this can be something more than teeth. Maybe surgery could be done under laughing gas. So he talked the head surgeon at the Boston General Hospital, John Collins Warren, into letting him attempt this painless surgery by using laughing gas, nitrous oxide. Now, the patient for that day chickened out and didn't show up. And so while he was there, he asked any of the students, the med students in the audience, if any of them had like a bad tooth. And one of the students said, yeah. So he said, come on down, I'll pull the tooth painlessly. At least we can see that. So the subject who had the tooth pulled later said he didn't feel any pain, but when the tooth was pulled, he let out a scream. So something happened. And the students, being far less well-behaved than you guys, just started jeering and shouting this guy down like, you idiot, you didn't do anything. That hurt like hell. He felt that. So he was ridiculed, and as he left, he heard the most hurtful thing imaginable shouted by one of the students. Humbug. Apparently that was a never forgive sort of thing to hurl at somebody back in the day. Now, he had a student named William Morton who had worked with him, and he knew that this stuff worked, but he didn't think they were going to get another chance with nitrous oxide, and plus it was very difficult to administer, and he wanted to start looking for other things that could work, and so he settled on ether. Now, ether had been around since the 1300s, so it wasn't hard to come by, and he was able to figure out that ether could anesthetize people very effectively, and a year, almost to the day, after the botched excision of that tooth, he talked the same surgeon into allowing him to try this ether-based anesthesia, and this patient had a salivary gland tumor that had to be removed. It was very big. It had invaded around his mandible and into his neck. This was not going to be a pleasant surgery by any means, so very difficult. So he, using this inhaler that he had custom made, was able to control the amount of ether that was in the sponge, the amount of air that was coming in, so that the person wasn't going to, asphyxiate. And they did 25 minutes of surgery without the patient even twitching. And in fact, when the patient woke up, he asked when they were going to start. So immediately, people knew that this was a huge thing. Painless surgery had actually come around, and it was there. And the surgeon, John Collins Warren, said to his students, "Gentlemen, this is no humbug. Hands up if you think we need to bring humbug back." Thank you. I know I'm talking to this audience, but yeah, humbug needs to make a comeback. So Morton turns out to have had a very checkered past as a con man. He actually would go from town to town, take out credit to open up stores, and then just skip town without ever repaying the money. One point, I guess he also kind of like attempted to marry women of high social rank, and he kept getting found out. Apparently, he was going to marry the daughter of a very influential Jewish merchant, and he got kicked out the day before he was scheduled to have a circumcision. So he was ready to commit full to these scams. So he was a questionable guy, and he tried to patent this, and he called it Letheon. The problem is, it's ether. It's not a product. It's a thing that everyone knows has access to. So he's trying now to obscure what he's actually using to cause this effect. Meanwhile, the Harvard chemist who he worked with, a guy named Charles Jackson, said, "Hey, I'm the one who turned you onto this in the first place. You should be giving me half the credit and half the royalties when we inevitably make a lot of money off this." Now, Charles Jackson was a very strange person as well. He had a history of claiming to have been ripped off and had things stolen from him. He claimed Alfred Nobel stole TNT from him. He claimed Morse stole Morse code from him. So he had a real chip on his shoulder about being denied the glory of having these discoveries go on around him. And he was damned if he was going to let anesthesia get out from under him. So they just both started attacking each other in the press nonstop. And it got so bad that the US government put up a $100,000 prize to whoever could prove priority in having discovered ether anesthesia. Now, that's 1860s dollars. That's a lot of, I would take 100,000 right now. Yeah, I know, I'm not proud, but it's even more back then. So Morton jumped in a cab and hurried to Washington, D.C. to plead his case, but he had a stroke along the way and eventually died a few days after that. Now, according to Sherwin Newland, a medical historian and surgeon, I haven't heard this corroborated anywhere else, but this is the best version of the story, so it's the one you're getting. But I've only ever heard this from Sherwin Newland's books and tapes, is that Charles Jackson was later attending a funeral in Cambridge, Massachusetts, and saw William Morton's headstone, this man he hated with a red-hot, intense passion. And the tombstone said, "William Morton, inventor and revealer of anesthetic inhalation, by whom pain in surgery was averted and annulled, before whom in all-time surgery was agony." Charles Jackson went acutely psychotic and never recovered and passed away several years thereafter in an asylum, and his grave is now in the same cemetery as Morton's. So if you're ever in the Cambridge area and you want to check out the feuding chemists and dentists' tombstones, you're free to do so. One last thing. 4 years before any of this, in 1842, a rural physician named Crawford Long had used ether to anesthetize people to take off small tumors or warts, do little amputations, things like that. And he hadn't really drawn attention to it. He was writing it up, but very lackadaisically. He wasn't working real hard. And his friends were finally saying, like, "Crawford, come on, there's $100,000. You should, push this, that you were the one who invented it." But he was, one of the few people who comes out of this looking well. He didn't want to really drive that home. He was an egomaniac, and he actually passed away immediately after delivering a child in his rural practice, passing it to his nurse and then dying. And no one ever got the $100,000, but the world did get anesthesia, despite the people who were involved with it. Now, anesthesia, the word spread immediately from the Massachusetts General Hospital. People knew how important this was, and so it was very quickly revealed by people in the know, hey, it's ether. Use ether. Ether will knock people out. You can do surgery on it. So it made it to England and Scotland very quickly. And a very well-known surgeon there, Dr. Robert Liston, had really tried a lot to improve surgical practice. He'd actually tried to have patients mesmerized, or what we would call now hypnotized, before surgery, and it seemed to work, but it took a very, very long time to get someone into a catatonic state for you to do surgery. And he adopted ether very early. And yet another great old-timey quote: "This Yankee dodge beats mesmerism hollow." Translation: this Yankee dodge, this American innovation, beats mesmerism, is superior to mesmerism, hollow, by a lot. So basically saying this thing is fantastic. Now, he was a very well-known surgeon, but the fact that he was looking for ways to make things better is really to his credit. He was renowned as one of the fastest surgeons out there. He did a lower limb amputation in 2.5 minutes one time, but that speed could be a problem. He is, to my knowledge, the only surgeon who did a procedure with a 300% mortality rate. You want to hear about it? Okay. He's working on an amputation of the thigh, so pretty high up in the thigh, and so has to do it quickly. So they clamp down on the artery. His attendings are there helping out, moving the leg, and so he makes the initial slice, really cuts deep, and cuts into the patient's leg. He also cuts off 2 of the fingers of his assistant, who then jumps back screaming, causing an elderly man in the front of the surgical theater to have a heart attack and die. The patient and the attending later died of sepsis from the infection, hence 3 deaths for 1 surgical procedure. So another fun thing is Robert Knox was the anatomist that Burke and Hare sold bodies to in Edinburgh. These two both worked in the same area. And when Robert Liston knew that Knox was getting patients of his delivered by Burke and Hare, he actually walked in the middle of a lecture and punched Knox in the face. So just contemplate. Let's pick on my favorite guy, Dr. Pankey. Just imagine Dr. Pankey walking up here and just slugging me solid for no good reason. That's would have been about the same feeling right there. So ether had made it to England and Scotland, and another surgeon named James Simpson thought that we should look at other things too. One problem with ether is it's kind of irritating, and apparently, I don't know, but apparently it's very hard to titrate. Like the dosage to get someone knocked out but still be revivable is very slight, and they're still going to feel some stuff if they're not far enough under. So he was trying to come up with new ways to knock people out with anesthesia, and he would have his friends come over and they would sample possible anesthetics. And yes, that's exactly what it sounds like. They would just kind of sniff whatever concoction they could come up with. And one night they had chloroform. And they all sniffed the chloroform, and according to the story, they then woke up underneath the table, and somebody ran over to the windows and threw them open to get the fumes out. It's lucky they didn't die. But he basically realized that chloroform was an even better anesthetic, and it was less irritating, took effect faster, and it started being used both in surgery and in childbirth. Now, chloroform and ether, for that matter, are flammable, so there's some dangers associated with their use. But it was also, there were objections to this based on other considerations. Some clergy actually said that it should not be used in childbirth because it would rob God of the deep and earnest cries of a mother in labor. However, those criticisms stopped instantaneously when the Queen had chloroform-assisted childbirth. So she was delivered of one of her children, Prince Leopold, with chloroform, at which point everybody stopped criticizing it. Fun fact, John Snow, the guy who figured out that the Broad Street pump was responsible for a cholera epidemic, was also the person who delivered the baby. So he was involved in this chloroform anesthesia and applying it to gynecology and OB-GYN activity as well. So surgery can now become painless, but it's still a last resort, because what is probably going to happen to people a fair number of times if they get cut open? Infection. There's no idea about infection. There's no germ theory to really explain it. One of the actual main chemistry had come a long way. So one of the theories, which is not a bad theory, it's wrong, but it's not a bad theory, was that when the body was opened, oxygen in the atmosphere started to erode the tissues. They would oxidize, and it was thought that that's one of the things that caused that surgical infection. So surgeons could spend more time doing surgery, but the rate of surgical infections remained terrible, and it was a terrible way to die. And the unhygienic nature of surgery didn't help either. Because there was no germ theory, there was no even attempt to make things sterile or even wash them. Surgeons actually wore black frock coats, and it was kind of considered a badge of honor to have the dirtiest, most pus-stained, bloody frock coat when you're operating on your patients. They'd drop a scalpel, they'd pick it up, strop it on the bottom of their leather boot, and go back to cut as well. So essentially, it was really, really good at spreading infection because there was no theory about that, and it was kind of seen as part of the mystique of being a surgeon to have kind of all this blood and guts going on. It was a real problem. So, Joseph Lister is the name of the person who really kind of brought us out of that. Joseph Lister was a Quaker, and he had a few things going for him. One, he was a wonderful human being, as opposed to many of the other people here. Truly humble, persistent, good person overall. So let's enjoy those people when we find them. And second, he had been raised in the Quaker tradition to work hard, but also to have interests outside of his vocation. And his father was actually a microscopist. So he had done a lot of work with microscopy, figured out how to actually solve some problems of the color hues and spreading differentially when they go through a lens. So he was actually, raised learning how to use a microscope. And he started researching inflammation and infection and was able to read the work of Louis Pasteur. And he thought, if these little germs, these animalcules are causing wine to go bad, silkworms to rot, maybe there's something going on in surgical wounds. So he started looking at different surgical types of pus under the microscope. And sure enough, once he figured out how to stain for it, once he figured out what he was looking for, he noted that different kinds of pus contained different little, what we would now call bacteria. Laudable pus, that pus that Galen and all those other people throughout history thought was a good thing, was caused by staph. So Staphylococcus, which doesn't tend to be super aggressive. It tends to stay near the infection site, doesn't go centrally. It's not a good thing by our standards, but it's one of the more benign infections. Smelly, kind of thick pus, that was going to be streptococcal, and that does tend to move centrally and can be a real problem. If the person's immune system isn't really on top of it, that could be fatal. And worst of all was this watery, purulent pus. That was a clostridial infection called gas gangrene, and that was, I would imagine, inevitably fatal. But he's able to show that these different molecules of these animals were there in each one of these things. So he started looking at ways for antisepsis to work, and Pasteur had done a lot of this work already. So he came up with something. He wanted to find something that could be used surgically to kill off this what we now would know as bacteria, and he found that carbolic acid, now we call it phenol, did a really good job of it. So he would spray the area around the incision with phenol. He'd spray the incision with phenol during the procedure. He'd spray his hands. He'd spray his instruments. By our standards now, he went way overboard. But at the time, this was the first actual effective way to stop infection from taking hold. And he really had good results. He published that he'd been able to cure people with compound fractures. A compound fracture at that point was considered a death sentence because if your bone gets broken and pierces the skin, you're almost certainly going to have dirt, other material get in there, set up an infection and kill you. And he showed that he was able to do the surgery on people with compound fractures, and the use of this carbolic acid led to their surviving the procedure more often than not. But this finding was not well received in the surgical community because it was the antithesis of everything that a surgeon was supposed to do. What did we say a surgeon was supposed to be when they operated? Very fast. This was not a fast procedure. You had to take time to spray down things with carbolic acid. You had to slow stuff down. So it really kind of went against the grain at the time. There's a Philadelphia surgeon, a guy named Samuel Gross, and this is a very famous painting by Charles Aikens called The Gross Clinic. It's because his name was Gross, but it's showing this pre-Listerian surgery. So you can see, actually you got Gross showing himself in his painting. He's the guy actually shown taking notes up behind there. You can see the surgeon there. And you can see the mother of the person on the table wincing away at the blood. Gross was very anti-Listerian because he felt that it was the oxygen that was responsible, and he thought you had to keep surgery fast and was very against adopting Listerian methods. But over time, Lister was able to convince people very gradually, first in other countries besides England and America, but it got hold that this antiseptic method would work. And Akins, the same painter, made this quite a bit later, and it's another picture, but this is a post-Listerian surgery. What do you notice? What jumps out at you most about that painting versus this one? What's that? They're wearing white. If you're taking pride in your surgical care, your skill, and you're trying to avoid infecting people, are you going to be showcasing your, nasty looking black frock coat anymore? No, you're going to show how clean you are by having white, which is going to show any kind of nastiness on it. So Lister, his findings are validated in 3 different ways. One, he had demonstrably superior outcomes, and if anyone was willing to listen and give him a chance, he could show them that. And he was a very effective communicator, very persistent. He wasn't a big showboat person, but he did a good job of it. He was very humble, good at communicating, and persistent. And sadly, one of the main reasons sometimes we have new things take root is that the older echelon of opponents die off and newer people come in who are less resistant to that change. So essentially, antisepsis worked and was only really replaced when we came up with asepsis, coming up with ways to sterilize things and not allow infectious material into the surgical suite in the first place. So we can see here, this is the Agnew Clinic, again, showing that post-Listerian view of surgery. So now we have anatomical expertise, anesthesia, and the ability to stop most of these post-surgical infections. And so this new era where you can really do a lot of amazing things is really best encompassed by an American surgeon named William Halsted. So William Halsted was basically the turning point for making American surgery into the premier surgery in the world. He began in New York after training in Europe, because at that time American medical education was pretty flimsy, so high-class rich people like Halsted would go to Europe to train and come back. He'd been exposed to Lister's methods, knew they worked, and actually when he was told by the hospital where he worked that he couldn't have a Listerian theater, he actually got together some friends, raised funds, and put a tent outside the hospital, and that became their Listerian area for doing surgery. They got the phenol there since they weren't allowed to do it in the hospital. He wrote lots of papers. He was incredibly interested in research, worked day and night, and tried to find new and interesting ways to work with surgery. And he was really just rocketing the top of the medical world. There's only one problem, not really his fault, but the thing was, he was looking at a new topical anesthetic. Instead of knocking people out completely, maybe we could numb peripheral nerves and do procedures without having to knock them out completely. And that was cocaine. So they would work on injecting cocaine to numb nerves, see what kind of watersheds were there. And essentially, cocaine was widely available. You could buy it in a drugstore. You could order it through a catalog. It was available in toothache drops. Yeah, kids back in the day, are they whiny? Are they fussy? Give them some heroin. Give them some cocaine. All that stuff was available and was used to kind of keep kids calm, keep people happy, and kind of unaware of the bad effects. Halsted, in the process of doing these, and his friends in the process of doing this research, started to think, not only is this numbing my nerves, I feel awesome. I can party all night and I can write all day. And so they would just, they really went up to the highs of cocaine addiction, sadly followed by the lows. So a lot of them crashed out, a lot of them died. Halsted very nearly died from overdose and just sheer malnutrition from being addicted for several years. And when he finally got around to writing his paper on the effects of cocaine, he was deep, deep, deep in its grasp. And to demonstrate that, I'm going to take a deep breath and read you one sentence from that paper. Neither indifferent as to which of how many possibilities may best explain, nor yet at a loss comprehend why surgeons have, and that so many, quite without discredit, could have exhibited scarcely any interest in what, as a local anesthetic, had been supposed, if not declared, by most so very sure to prove, especially to them, attractive. Still, I do not think that this circumstance of some sense of obligation to rescue fragmentary reputation for surgeons, rather than belief that an opportunity existed for assisting others to an appreciable extent, including me, several months ago, to write on the subject in hand the greater part of a somewhat comprehensible paper which poor health had disinclined me to complete. That's not the writing of a healthy person. So he had crashed and burned. A lot of his friends who investigated with him had died. And he really was kind of down in the dumps, and in the dregs, and he was only rescued because a really good friend of his took him under his wing and brought him to a new school that had opened. This is Johns Hopkins, and essentially let me back up, sorry, came to Hopkins, and his demeanor had completely changed. He was now very slow, very meticulous. He'd kicked cocaine. He'd had to go to rehab or a sanatorium a couple times to kind of really get over it. But his technique had become incredibly precise, and his surgeries and his investigations really brought a new level of sophistication to surgery. So here are some of the illustrations. He was actually a really good illustrator as well. He drew these, and he basically invented the modern ways that we repair hernias, a very common injury. He advanced the first thyroid procedures. Thyroids had been off limits for a long time because if you nick them, you can cause a massive metabolic reaction. Worked on aneurysms, conducted the first gallbladder operation, removal on his mother on a kitchen table because he knew she was having a gallbladder attack and she was going to die if he and his family didn't hold her down. So he actually did the surgery on her in their house. But he did a great deal of anatomical research and brought that to the new sophistication of surgery. And it said that his procedures were practically bloodless. He was so meticulous about tying off and cauterizing every little artery, every little vessel that was there. And something that he's really famous for and kind of unnecessarily vindicated against these days is called the radical mastectomy. So the Halsted radical mastectomy, make no mistake, it's a brutal procedure. But it was the first thing that could actually treat breast cancer effectively. The treatment for breast cancer up until that time is illustrated here. First, the patient smokes opium. Then her breast is pierced with iron needles. Ropes are tied to it, traction is applied, and then a red hot knife is used to cut the breast tissue off, and then cautery is applied. The calm look on her face is the most horrifying part of these illustrations. Now, if you guys think back to lymphatics, you think back to spread of cancer cells, is that going to work? No. So you've mutilated somebody and they're just going to die of the same disease anyway. And so breast cancer in those days was a lingering, slow death that isolated people from their friends and families because of the ulcers that would form. And Halsted, doing his anatomical research, has figured out that the lymphatics were involved and that to really get to the breast cancer, you had to not only remove the lump and the source, you had to remove the lymphatics. And so his procedure involved removing the pectoral muscles, as much of the lymphatics in the axilla as possible, and it worked. Now, we now have way better options most of the time. This can still be done in the case of an advanced spread into the axilla, but early screening and being more cognizant of the lymph spread allows us to be a little bit better about it. But the process got started because that knowledge of how the tumor spread was applied to the treatment. And you can see here an illustration not only showing that what the procedure looks like, but the level of detail that was involved in these investigations. So Halsted he didn't invent it, but he rapidly adopted the residency system that we use today, where you have senior students training junior students, training even more junior students, so that there's a hierarchy that is totally constantly moving upward. So as the top person goes away, there's a new top person ready to step in, and you have this escalating chain of responsibility. So this is how he was able to keep his practice going. And you can also thank Halsted. He invented the surgical glove. It was all bare hand up until Halsted. And he did that because his nurse, Carolyn Hampton, had a bad reaction to the phenol that was used for disinfecting the instruments in the Listerian sense. So he called the people up at Goodyear, because he was a rich New York old money kind of guy, said, I think it'd be cracking if you guys made some gloves out of that new vulcanized rubber that you have. And they did, and now we have gloved hands when we're in the anatomy lab and in surgery. And they later got married, by the way, so they were that was kind of the first surgical love story I'm aware of. Now, he had kicked, as far as we can tell, his cocaine habit, but he had a very erratic behavior kind of pattern as the chief physician, the chief surgeon. He would just disappear for months. He was known to sometimes walk away from a surgery and then the next person in line would have to step in and finish it off. And it's been since documented by people he worked with after he died that his cocaine habit may not have been totally kicked, but he had gotten off cocaine by getting onto heroin. So he did all these amazing things while having an active addiction. And it just blows my mind that somebody could be that effective and yet mask it so well. Now, you can debate how well he masked it. He was very socially awkward. He was mean and kind of condescending to his students and his patients. But he did all these things despite having this massive chain around his ankle the whole time of that addiction. So several of his students are people you may have heard of. Harvey Cushing. Now, when you think of Cushing, often you think of endocrinology, but Cushing was actually a neurosurgeon. And it's because he figured out how you could go after the pituitary to stop Cushing's disease and so forth that he got his name. Another great name, Walter Dandy, another person who became one of the early neurosurgeons. Both worked under Halsted. So Cushing was very much influenced by Halsted in terms of surgical technique, but he really disliked him. William Osler, another professor at Johns Hopkins, kind of the early pioneer in internal medicine, was kind of more his case. And Cushing was yet another person who was really good at illustrating. So this is a image he drew of coming up with how to go after brain tumors. And it actually is William Osler who's the subject there. And he did over 2,000 brain operations during his career. He was the one who actually was able to figure out how to actually use cocaine effectively to numb peripheral nerves and do things like that. Came up with lots of different things to treat, and the rate of kind of mortality during brain operations dropped from 90 to 8% during his life. Now, one interesting thing is he also, his first real surgical success was treating trigeminal neuralgia. Now, you guys remember trigeminal neuralgia, second years? You have a shiver of fear go down your spine at the mention of neuro. So it's trigeminal neuralgia. It's a horrifyingly painful condition where the sensory nerves in the face are just screaming a lot. And his treatment for this was to find a way to go after cranial nerve 5. And he actually figured out he could go in and cut the whole nerve. Now you've just desensitized the person's entire face. That was better than the trigeminal neuralgia. This actually helped people because the inevitable outcome of trigeminal neuralgia untreated was suicide. Now, it's not that pain makes suicide inevitable, but pain can lead to lack of sleep. Lack of sleep can lead to desperation, very poor decision making, and that's why it was a death sentence up until this procedure came along. Now, obviously, we have better ways to treat it now, but that was the first time that had been applied, that neuroanatomical understanding had been applied to fix it. Now, Walter Dandy was kind of, I don't want to say tragic figure, but it's kind of interesting. Cushing was, again, old school money. He was from Cleveland, but he was old money, very aristocratic. Walter Dandy was a scrappy young, kind of like a working class guy, and he had a massive, massive rivalry with Cushing. But no one's really sure if Cushing knew that that rivalry existed. So Walter Dandy did a lot of work in neurosurgery, described CSF circulation. If you've heard of Dandy, kind of malformations of the cerebellum, that's got his name attached to it. He came up with aneurysm clips. He's the one who kind of figured out how herniated nucleus pulposi can actually cause impingement of a nerve when you have a slipped disc and so forth. And he invented something that thankfully we don't have to use anymore. It goes by another great long name, pneumoventriculopography. Now, back in these days, x-rays were brand new, and that was the only imaging modality that existed. Prior to that, surgeons doing any kind of neuroprocedure had to base where they were going to open the skull on a very thorough neurologic examination. So think about looking at all those deep tendon reflexes, checking pins and needles response, checking fine touch, and saying, yep, we're going to open the skull right here, and that's where the tumor is going to be. You better be really good at doing that neuro exam. So when x-rays came along, it helped, but it was difficult to find tumors in the brain because they have roughly the same consistency as the brain itself. So Dandy came up with the horrifying yet effective method of opening the skull, draining the CSF, taking an x-ray while there was air in the ventricles, and then he could actually see tumors or other space-filling lesions as distinct from the surrounding air. Then suture everything back up, wait for the CSF to refill that area. So they made brain surgery a reality before these modern imaging modalities that we take for granted now, like CT and MRI, were invented. They actually did the work before they could know what they would see underneath the skin. So moving on to a little different flavor of surgery, Johns Hopkins was also the place where the first, what we consider heart procedure was done. It was done because Dr. Helen Taussig, who was a graduate of Hopkins, became a cardiology fellow there, and after graduating didn't get the position she'd wanted and was instead offered a kind of job in the pediatric cardiology wing. Now, pediatric cardiology in the mid-1900s basically was you try to make these poor children as comfortable as possible until they die because their heart is not working, it has a hole somewhere, and there's not much we can do. She got the job and started looking at ways that she could try to treat it better. She consulted with another woman physician named Maud Abbott up at McGill in Canada, who was an expert on cardiac malformation. So she had a collection of malformed hearts and tried to look at ways to figure out what was wrong, where there were shunts one place or another. And one of the toys that she was able to get was a fluoroscope. So she could actually look at the blood flow through the hearts of her patients to try to figure out where the problem was. The only thing was there wasn't anything she could do about it. So she was trying to figure out how they could take the knowledge of where the problem is and actually get a surgical fix going. Now, much later in her life, this was a photo taken, I think, for Life magazine, but this photo is a lie. Okay, get ready to be jealous, osteopaths. She was mostly deaf. So the stethoscope is not something she ever actually used. So she had to detect the thrills and the murmurs of her patients through palpation only. So she had to palpate all those heart defects and figure out what was going on with her kiddos that way. So get your fingers that well attuned and you can do some amazing things. So she listened with her fingers, was able to figure out with the fluoroscope as well to validate where the problem was. And her research and text basically founded pediatric cardiology. Now, that was impressive enough, but she was also involved in coming up with a way to actually treat the first real heart problem. And she went to the chief of surgery at Hopkins, a guy named Alfred Blalock. He's on the left. And Alfred Blalock was chief of surgery there. He was kind of old school Southern, kind of had a little Southern drawl. But he listened to the problems that she had, and she was telling him that her patients with tetralogy of Fallot actually did better if they had a patent ductus arteriosus, if part of their blood vessels were connected inappropriately because they had a shunt. And her thought was, well, these patients with tetralogy, when they're really about to die, would benefit from that shunt. So we need to figure out a way to actually make an artificial shunt between the subclavian artery and vein. But she's a pediatric cardiologist. She doesn't know how you're going to do that with a living person. Now, Blalock had done a lot of work on surgical shock, and he had done that because he had the best laboratory assistant in the world, a guy named Vivian Thomas. Vivian Thomas was a black student who wanted to go into medicine, but his life savings were wiped out when his bank defaulted and went out of business. Back in those days, there was no insurance for banks. If your money was in that bank and it shut down, you were out of luck. So he took a job at Vanderbilt working with Blalock, who realized this guy was incredibly skilled with his hands and was soon running all of the operations that he was doing to figure out how to cause surgical shock in dogs and then treat it so that soldiers in World War II would have effective treatments for that sort of shock when they encountered it on the battlefield. So they got to work on how to make a surgical shunt that would help these children with tetralogy of Fallot. And the problem was the patient that they had who was going to go under the knife first took a real turn and she was going to pass away. It's a little 3-year-old girl and she was about to pass away. And so they had to do the operation. The problem is Blalock, the chief of surgery, had only done the operation once and he had only done it on a puppy. So Vivian Thomas, his black lab assistant, was the only one who was skilled enough to do it. But given the racial undertones in Baltimore at that time at Hopkins, there was no way on earth they were going to let this lab assistant do the surgery. So Alfred Blalock got dressed out to do the surgery, got started, and immediately said, I need Vivian here right now. And so he got a stool. He got to stand over the shoulder of the chief of surgery and say things like, no, not that artery. Yeah, suture there. Okay, pinch it a little bit more. And so basically they were able to get that procedure done. And they said that They didn't know it was a success until they removed the last clamp and they saw this little blue baby with tetralogy turn pink all at once. Now, if that sounds like a great story, A, it is. B, you can watch it. It's on HBO. It's called Something the Lord Made. It's got Alan Rickman as Blaylock and Mos Def. And if you want to hear Severus Snape talking like this, it's your movie. So it's really good. I cried manly tears at the end. I'll own up to that. But essentially, this was the first heart operation. Up until then, the heart was off limits completely, and people who had tetralogy, children with tetralogy brought them there very, very quickly, and it became a real clearinghouse for people with tetralogy of Fallot. So the Blalock-Taussig, which should be the Blalock-Taussig-Thomas shunt, basically allowed bypassing of the blood so that you had mixing of it rather than complete cyanosis when tetralogy went really bad. So people who got this procedure lived for quite a long time, and in fact, they eventually stopped doing it only because the heart-lung bypass machine was invented, and they could actually then go in and repair the error of the heart rather than having to make a peripheral shunt nearby. So that heart-lung bypass device is what finally allowed people to go in and actually deal with the heart, straight away. So Vivian Thomas did receive an honorary doctorate, although obviously, sadly, he was not given the recognition he deserved at the time in the 1950s. He was recognized much later in his life and remained working at Hopkins, training surgeons, and most of the cardiac surgeons who trained in that era trained under him. So open heart surgery has become an issue that has been not resolved, but made a lot better. Now the next big thing was transplantation. If you have an organ that's not just damaged, but non-functional, it's shutting down, what can you do about it? Well, kidney transplants between twins were carried out, and it was shown to be feasible, and was actually, the person who did that was awarded the Nobel Prize. And there were two researchers in California at Stanford who were working on canine heart transplantation in the anticipation of human procedures. They're trying to figure out a way to carry out heart transplants. So they were pretty shocked at the news one day that a successful heart transplant had taken place in South Africa by one of their former students, a guy named Dr. Christian Barnard. So heart transplantation suddenly became very feasible. Now the problem is, initial outcomes were not great. The first patient, I believe, lived for less than a week. He did live after the procedure, but people who got this lived for a little while, but not very long. Because what's the problem with transplants? Rejection. Immune rejection was a phenomenon, much like infection, that wasn't understood or appreciated at the time. And so the sudden rush to do all these heart transplants dwindled off because the immune rejection phenomena wasn't well understood. Now, thankfully, Shumway and his colleagues didn't give up. They thought, well, maybe we can find a way to suppress this immune rejection now that we've got the technical side of heart transplantation taken care of. And he was actually able to do the research and come up with the fact that you could get immune depressive things like cyclosporine to people, and that would actually allow the transplant to take for an extended period of time. So at that point, we're kind of, in 1984, we reached kind of the status quo we have now, where the technical aspect of the transplants is far less difficult than actually getting the organs in the first place, which is why, as you may have read in the news, there's a lot of interest in porcine organ transplants to humans, interspecies, because there's just not enough hearts, kidneys, etc. to go to all the people who are on the waiting list for those transplants. So that's bringing us up mostly to the current age. There's a few new interesting things that have happened. Stem cells, printing of cells onto a three-dimensional lattice, actually 3D printing organs and cells is something that's been taken up and is being actively researched. So actually we had a kid with spina bifida in 2006 whose bladder was tonically contracted. The spina bifida caused nerve damage that didn't allow the bladder to relax. The spinal cord wasn't there, so the smooth muscle cells were just constantly contracted. And that caused kidney disease because that urine has nowhere to go other than back up into the kidney along the ureter. So the cells from this kid's bladder were taken and then pasted onto a scaffold of collagen that was then retransplanted back and actually worked. It was wired back in to the kid's bladder and allowed that to work. There's also been a lab-grown trachea that was in 2011, and that seems to be pretty much where we're at right now with the idea of regenerative medicine. But in your guys' career, this is probably going to be huge. Now, like every medical discovery, much like the big AI bubble right now, you will be told multiple times, this is the thing that will save everything. This is going to be the brand new world. And then the hype dies down. It's not that great, but it is good because we've gotten progress. We've made progress there. So don't believe the hype 100%, but be ready for the benefits that it brings when these new programs and things come around. All right, so we've covered surgery. As a quick little exercise, this is new for you guys. Let's follow one procedure and see how it's morphed over the years to give us something that we're very familiar with now. And again, as people interested in surgery, may be something that you wind up working your career on. So if you've heard of the Hippocratic Oath, or even a book that came out a few years ago called Cutting for the Stone, there's a part of the Hippocratic Oath that says, I will not use the knife even upon those suffering from stones, but I will leave this to those who are trained in this craft. Now, for some, this was taken as an idea that Hippocrates discouraged surgery. What it really is more of a professionalism thing. It's that there were already people out there whose job was to cut for bladder stones, and you don't poach other people's patients. That was basically what that was about. Have you guys ever heard of the word quack applied to a doctor? Like that person's a quack? That was more of a medieval thing, but it actually means a doctor who is practicing outside the scope of their practice. So it would be like a physician who's prescribing herbs, or a surgeon who's cutting hair. It was someone who was doing someone else's job and taking money away from that person. And that's basically what Hippocrates was getting at, is that you weren't supposed to be cutting for the stone because there were already people who did that. Now, one thing about that that's really interesting is the prohibition in Greece against cutting into the body was pretty strong. So if somebody had a bladder stone that needed to be removed, they would pay the guy would do the procedure and immediately run away, and then the same people who paid him to do the procedure on their relative would then fling rotten fruit and stuff at him as he left town because, oh, how dare he cut into that. But it was basically all pantomime. They knew it had to happen, but they also had to express the proper level of revulsion that their loved one had been cut into. Now, bladder stones had been around all throughout human history. We can actually trace some back to ancient Egypt that had been removed from people, but removing them is something that had been attempted in many, I can see a lot of you squirming right now, I agree, had been practiced in many cultures. So we have evidence for Chinese, Arabic, Hindu, Roman, Greek, procedures to get the bladder stones out. And strangely, almost universally, the perineal approach was taken. Perineum, that area between the scrotum and the anus, or between the labia majora and the anus, is what they would cut into to try to get to the stone. And you can see they've trussed this guy up, moved the genitals up and out of the way, and then his friends are holding him tight so that the surgeon can go in and try to fish it out. So they would put a catheter in the penis, in the case of a male, try to fish around and find the stone, and then use the incision to go in and pull it out. I should mention there's a famous Hindu physician surgeon named Sushruta who had actually described this far back as 600 BC. So hopefully more on him at the next talk. But this is a really nasty procedure. That perineal incision is not something to take lightly. So to avoid cutting, sometimes they would come up with what were called these lithotrites. And it was basically inserted down the shaft of the penis. You don't find as much evidence for this procedure in women, although I did find some references to it. But basically, this would be inserted down the urethra of the penis, and then the stone would be grasped with it, and they'd try to crush it. So that they'd try to crush the stone to make it something that could be passed with the urine thereafter. And this might be what you could consider your first minimally invasive procedure. But no matter what approach was used, you couldn't really visualize and grip these things well, and it was going to be a very kind of, very temporary fix, because the things that are still at the core of finding these bladder stones and whatever kind of crystalline deposition disease is there is still going on. So visualizing the area became a major concern, and in fact, there's an Arabic physician, Abu Qasim, who used reflected light to view these organs, and reflected light actually was something that physicians and surgeons used from that day up until now. So if you guys have ever seen old-timey doctor shows or movies, you see that big little thing on their head, that's actually a reflecting mirror. So they would use that to just kind of get the light directed at whatever they were looking at as you go. So you don't see those as much anymore. Anybody ever seen a real person wearing those? Yeah, we have LEDs now, so it's unlikely you'll see much of them, but that's what they were for. Now, visualizing the inside of the bladder was one of the first things that led to endoscopy. And I learned something new in preparation for this session because I didn't know the difference between endoscopy and other procedures. Endoscopy is visualizing hollow organs. So basically, we had to find a way to illuminate the endoscope, and in this case, we see a rigid endoscope to do an esophageal viewing. Candles and mirrors were used to try to reflect light down the scope so you could actually look at the esophagus, the bladder, the rectum, and see what was there. So this was actually developed by Philip Bronzini, and his colleagues at the time basically thought it was a toy. Like, this is stupid. There's no why would you do this to like look inside the bladder and see a stone or see a tumor? But it was very quickly adopted, and endoscopy became a fairly regular practice, not for most, but for some, to try to view what was the problem in the rectum, the esophagus, the urethra, etc. Now, the problem is you had to have the light source close by. So you have candles. Later on, you have platinum wires with incandescent lights and so forth. They're all very hot. Those incandescent lights, which you don't see as much anymore, for the energy that got put in, only about 3% of it turned into light. The rest turned into heat. So these procedures had to be pretty short because the thermal damage and the burning that would occur to the patient were not insignificant. Now, I mentioned endoscopy is looking at a hollow organ. Laparoscopy, and again, this is new to me, so I feel happy I've learned something new, is when you use endoscopic tools to look inside a body cavity. So something that doesn't have a natural opening to the outside. So the thorax, the abdomen, the pleural space, that's what technically laparoscopy is. So this is how we got our start with minimally invasive surgery. Started in gynecology with a guy named Kurt Sem in Germany, and he thought that using these endoscopic tools that were getting better and better could actually be done to look in the body cavities. And he came up with a lot of the early instrumentation that was required to make this happen. Now, being a gynecologist, he did not get much traction when he tried to take this to general surgeons. The prevailing idea at the time was big problems require big incisions, and that, we're not going to let this gynecologist come tell us how to do our job when we are doing just fine, thanks. But Sem was undeterred and kind of came up with a lot of the things that are the basis for these laparoscopic procedures now. So loops to control hemorrhage, ways to pump gas into the abdomen to create a pneumoabdomen or a pneumothorax that you can actually see in, and thermocoagulating loops, things of that nature. I thought this was interesting. They started with oxygen and then later switched to CO2. And they said that they switched to CO2 because it's more easily absorbed by the body after the procedure, doesn't cause as much irritation, and doesn't have other side effects. And I was like, what are the other side effects? Then I'm thinking oxygen, maybe an explosion was one of those other side effects because oxygen is very volatile. Now, I just love this quote, so I felt obligated to put it in there. So Kurt Sem really did kind of push through despite a lot of naysayers, and essentially a combination of restlessness, nervous energy, and individualism allowed these people to face the difficulties with which they were confronted. And so laparoscopic gallbladder removal started to be not just happening, but happening very regularly starting in the 1980s. And then the 80s and 90s, laparoscopic procedures and minimally invasive surgery really took off. And in fact, much like other aspects of surgery we've seen, it took off to the degree that the people who had started it lost control of the quality control, and just anyone could really get into it. And there's a real kind of Wild West atmosphere at some point in the 90s where people who maybe were not that qualified, didn't have anything overseeing them to stop them from overreaching their skill level. But growth of that field is definitely there going today. Anybody here seen one of these robots or a Da Vinci? Yeah. So not only are these laparoscopic, they're robotic, and they allow the surgeon, he or she can actually, maneuver these different arms in different ways. But what I love is you can scale the response. So I can move my arm a foot, and that's going to move the robot arm an inch. So you can have this massive scaling and very precise control, along with haptics that push back at you when there's resistance encountered by the probe on the inside. So it's fantastic. As always, don't believe all the hype, but some of the hype will indeed pan out and things will work out well for you. All right, that is the end of this talk. Next talk is scheduled for next week, although I may look at changing it because I think there's an OPP review, and I don't want to go head to head with something you actually get graded for. Speaking of graded for, we have an elective going. So first years, if you're interested, between Essentials 1 and 2, we have a History of Medicine elective, and essentially we just have remote meetings during that week. If you want to kind of pop in, we'll talk history of medicine, you get a little independent project. It's not meant to be a huge slog. It's not meant to be something that takes you away from being able to relax after Essentials 1, but if you find this interesting, you're more than welcome to let me know, and we'll go from there. Thank you guys very much. And we got time. Any Q&A or any just observations on how horrific that lithotomy position was? And if you ever wonder why they call it the lithotomy position, now you know. Yeah. How do they diagnose bladder stones? Basically, the person would get sicker and sicker. They'd go into kidney disease. They'd have difficulty passing urine. I think Samuel Pepys, who was a member of the Royal Society and kind of a famous diarist, like he recorded everything about his life. He had one and he had the operation done. So he was recording like how he could only urinate like, for a few seconds at a time before the stone would block it. Then he'd have to relax, urinate some more. So because it had been around for so long, when people got it, they knew what the signs were. Interestingly, I'd love to get a hold of one of these, but apparently there's some that were so big that they kind of looked like little devils because they had like a nose going where the urethra was, and they even had two little horns going up the ureters in the back. So they could be that big and fill almost the entire bladder. So hint, hint, anybody comes across one of those, I'd be happy to take it off your hands. Yeah.
So in the beginning of like the dissection era, body snatching was a big thing. At the beginning of the organ transplant era, was organ snatching a real thing?
No, but great question. Organ snatching was never really a thing because there was regulation put in very quickly to prevent that. So organ harvesting was very tightly regulated. However, because tissue harvesting was not regulated, tissue harvesting became very lucrative and very ethically dubious about 20 years ago, and I think continues to this day. So people whose loved ones pass away in a hospital will often get a visit from somebody who is portraying themselves. They don't say it, so they're not lying technically, but portray themselves as someone there's for an organ transplant. But what they're really there for are the bones that'll be ground up into bone paste for surgery. The tissues, so because it's technically not an organ, it doesn't fit the organ transplant criteria, and they're able to then sell that at a massive markup after they do so. None of that money going to the person's family who died and so forth. So just be aware, organ harvesting, very tightly regulated, tissue harvesting, not so much. And because so many people are making so much money at it, it's very unlikely that lobbying is going to allow that to be the case anytime soon. Are you intrigued and horrified? Yeah. We actually got a donor in the anatomy lab many years ago that we were told was, straight from the hospital, and the person's legs and arms were all wonky. We opened them up and they had PVC pipes where their femurs and their humeri had been because the tissue harvesting people had gotten to them. Yep, I agree. What's that? PVC pipe, yep. It was white at least, but that's as close as it got to actual bone. Yeah, so again, I'm not, I'm afraid, no, we're not going to go there. I'm not anti-innovation or anti-capitalism per se, but I think some things are best not exploited, and I'll put that on the list. Not exploited lightly, we'll put it that way, unethically. All right. There we go. I almost expressed a political opinion on stage at a public university. Holy crap. Okay, anything else? Any other questions? Yeah.
Are there still separations between surgeons and physicians?
Oh, yeah. So think about, it's better now. You think about the difference between DOs and MDs. There's always been a little bit of kind of like sometimes friendly rivalry, sometimes not so friendly rivalry. Same thing with physicians and surgeons. Now, again, any good physician and good surgeon appreciates what their colleagues bring to the table. But, just like anything else, you can have friendly kind of like ribbing of each other, but there can also be actual animosity or passive aggressive behavior hiding underneath that. So, just, if you hear little comments about surgeons this, physicians that, just be, it even gets more granular. Like Again, I brought it up earlier. Who's your typical ortho bro? You know, you're not thinking of somebody who's necessarily intellectually gifted, yet they have to be doing that job. Then think about your prototypical neurologist. Is that person even getting close to an actual patient if they have to? No. So, I mean, there are stereotypes in all these things. And as with all stereotypes, you don't apply them to individual people. You know, just let yourself, notice that when it's there. But, everybody's got their different practices. And because of that, people have their different approaches, which tends to build up over time to cause a reputation.
There's still countries where the training's separate.
Oh, yeah. Great. Wow. Really good question. Are there still countries where the training is separate? I think in the UK, students there, they go into medical school kind of as part of the undergrad. So they go in, it's a 6-year program, but it's kind of starting in the undergrad. And I think they quickly kind of diverge off if they're going to go into, say, internal med or into surgery. So it's not so much separate as it kind of splinters a little earlier. And one thing I found was really interesting is a surgeon in the UK, it's kind of an insult to call that person doctor. Because of that historical separation, they actually go by Mr. or Mrs. as like their honorific. Now, I don't know if that's 100% true everywhere, kind of in the British declined area, but it was really interesting. I saw a surgeon get really steamed one time. Dr. So-and-so, I am a surgeon. You will refer to me as Mr. Like, fine. America, it's the other way around, but Celsius, Fahrenheit, so forth. Yeah, we have our differences. Any other questions, observations? Anybody got any funny stories of surgeons behaving badly towards physicians or vice versa?
I got a good one.
Go for it.
So, nothing illegal.
Right, okay. I was getting more at like physicians talking bad about surgeons and surgeons talking bad about physicians. But yeah, that is definitely bad behavior. So, I'll just say, pay attention to what stuff you sign, and you can be professional and still pursue a relationship with people, but don't get a reputation as the creepy older doc who hits on all the young people coming through the hall. That's just bad in every job. When I got here, oh boy, the stories I could tell you about the older faculty, but I won't. So there we go. Some of them actually wound up being very long-term relationships and marriages, but yeah, big age gap between some of them. Yes. So during body harvesting, was there organ harvesting and so forth? No, because there was no practical reason that you would want a stomach or a brain or something like that. I mean, the only reason somebody would want it would be to do a medical dissection or research, so they would just take the whole body. One interesting thing is they got really good at it, so when these people would dig up a body, they wouldn't dig up the whole grave. They would just dig up the area near the head, snap the top of the coffin off, and then lift the body up through that one smaller hole to save time and effort. Yeah, they got really good at this horrible thing. And I just want to note, like, it really does blow my mind that within 120 years, medical schools can go to needing to steal bodies or use the bodies of unclaimed people to having a community that willingly and enthusiastically donates to the school. I think that speaks a lot about how that transition's been done and how it's right that we've made it clear what the importance of medicine is, because there were riots in London and in New York when medical schools were accused of stealing bodies, and there were actually people killed and medical schools raided when the public got upset about it. So laws were enacted to make sure that medical schools had access to these bodies, but the fact that we can now rely on the community to see the benefit of it just is, yeah, it's a massive turnaround for the good, and I'm very happy about it. I like my sleep. I don't want to be out in the graveyard. Well, let me rephrase. Halloween is my favorite holiday, so maybe lurking suspiciously but not digging up bodies would be more my way to go. All right. Any other questions, comments? Once again, give it up to Surgery Club and make sure you've signed in.